Perfect. So it's my pleasure. I think you've already heard a little bit from Dr. Hong, but it's my pleasure to introduce him as our next speaker, and with the topic of how to choose the site of LVA with ultrasound. Dr. Hong is the head of plastic surgery at Asan Medical Center and in South Korea. It's also very early morning there, so we are very grateful for his presence.
Hello, friends. My name is JP Hong from Seoul, Korea. First of all, thank you, Bernard and Dhruv, for the invitation to take part in the Boston Lymphatic Symposium. Unfortunately, this year it will be a webinar, but hopefully next year we'll be able to get together in person to share more ideas on lymphedema surgery. Today, my talk is going to be focused on how we choose the ideal site for LVA and in utilizing the color duplex ultrasound. As you know, the goal of all lymphovenous anastomosis is basically to reestablish the physiologic drain from the high-pressure lymphatics to the low-pressure vein. So the components of the LVA basically involves lymphatic vessels and how we find the vein. An ideal lymphatic vessel would be the one to choose functional and to choose a large lymphatic vessels to make the anastomosis easy. And the modalities to choose these kind of lymphatic vessels are MRI, LymphCT scan, and other modalities. And basically, for us, we use the LymphCT scan to see whether or not the involved extremity actually has a flow. And as you can see here in this arm, compared to the right, the left definitely does not have a flow. But it really limits in how to select the lymphatic vessel. The MRI is also a great modality to see whether or not they have deep functioning lymphatic vessels. But it's quite difficult to correspond to actually where the incision site is going to be. Ideally, the ICG would be the best method to locate the functional lymphatics, but in advanced lymphatic patients or advanced lymphedema patients, it's very difficult to visualize the lymphatic vessel due to the lack of penetration, which is only up to 1.5 centimeters. And as you can see, ultrasound has been used quite widely in the reconstructive arena, especially when designing perforator flaps. So here's an example of using ultrasound to map our lymphatic vessel. We usually like to use the ICG in patients like this with less severe lymphedema, and it's very clear that these are functional lymphatic vessels. And when we correspond with ultrasound, of course, we're able to see a lymphatic vessel. And in addition to that, we're able to locate our nearby vein, which really allows to have a very good idea where the ideal incision site could be. But it's a little bit more troubling as the lymphedema progresses. In this patient here with a stage 3 lymphedema in the upper arm, you can see that there's no linear pattern. We also did an MRI, which didn't show any. And of course, we'd like to double check with the ultrasound. And in this patient, unfortunately, we're only able to see the veins, and no lymphatics were seen in this ultrasound image. Now, this is not usually the case. In most of the cases, fortunately, we're able to see functioning lymphatics in the deeper region of the subcutaneous fat, even though the patient does not show a linear pattern in the ICG, as in this patient, or does not show a linear pattern in the MRI. Nevertheless, with good examination using the ultrasound, we're able to see this kind of functional lymphatics a little bit deeper than 1.5 centimeters and also isolate the corresponding vein. So just because it's advanced and has a stardust pattern, it does not mean that this patient does not have a functioning lymphatic vessels. However, there's no single modality that gives the best answer. So getting more information is actually beneficial for the lymphedema patients. In our case, the two most important modalities are ICG and the ultrasound. And what we also noticed was that for advanced lymphedema patients, ultrasound actually has the best sensitivity as well as the specificity. So today I'm going to be focusing on how we use the ultrasound to locate the ideal lymphatic vessel. Again, we know that the deeper collecting lymphatic vessels are located deep to the subcutaneous fat. So knowing that, we're able to target our search in that vicinity and try to find a larger diameter lymphatic vessel that is functional. Now, the ideal vein, of course, it has to be always near the lymphatic vessel, which makes it more easier to do. And if there's no backflow, that would be great. We like to also find the matching diameter of the lymphatic vessel if possible. And we also like to find a branch that's coming off from a larger vein to maximize the Venturi effect. So here's an example of what Venturi effect is. So basically, when you use a small vein draining into a larger vein, you could actually see this larger vein sucks in because of the increased velocity. It sucks in the lymphatic vessel when the patient is moving or exercising, or just with a mild compression, you're actually seeing that this Venturi effect really helps to drain out high pressure lymphatic vein into the main vein. So these are some of the key points that we like to consider as ideal veins using the ultrasound. Now, what kind of ultrasound? I think our speakers have also talked about the ultra high frequency, which is over 20 megahertz. High frequency is about 10 to 20 megahertz. Low frequency is 10 megahertz. The good news is that most of the ultrasound that your anesthesiologist use, if you don't have one in the department, has that probe that is relatively high ultrasound. So by using this hockey stick probe, we're able to identify good lymphatic vessels because this has up to an 18 megahertz probe. So here's a typical example of how we use the ultrasound. As you can see here, the patient's lying down. This is a hockey stick probe with around 18 megahertz frequency. First, we do the ICG, and with the aid of the ICG, then we try to locate the vein. However, even if the ICG does not show anything, we then start to locate the vein. So first of all, we're setting the frequency, as you can see here in this mode, set the depth around 1.5 or 2 centimeters, depending on the thickness of the skin or the subcutaneous region, and aim for, again, for that deeper collecting lymphatic vessels, which are located in the deeper plane of the fat. First of all, and then we like to also set, once we find the lymphatics, we like to set to a color mode to find the accompanying vein, which is nearest to the lymphatic vessel. So first of all, we'd like to identify the superficial vein first, because we know near the superficial veins, there is a high chance of having a lymphatic vessel. In order to actually see the vein, we like to do the compression test. The lymphatic vessel does not collapse completely while the vein collapses. Another mode is using a color mode, a duplex, to actually find if there's any filling of the vein. So again, if it's easily compressed, then there's a high chance that it's a vein. If it doesn't, if it's it is a lymphatic vessel. So this is basically how we do to first find and search the search the vein. So again, here with the color mode, we're able to double check once we've marked the suspicious vein, and then we double check with the color mode, confirming where is the vein. You could, if there's also a poor vein signal, you could slightly massage the leg, and by massaging the leg, you're able to actually see a better refill under the color mode. As you can see here, during the massage, the velocity becomes a little bit faster, and the signal becomes a little bit faster as well. And now we're trying to find the lymphatic vessel near the superficial vein with an axial and a transverse to actually see the pathway of the lymphatic vessel. Again, the lumen is slightly seen, and you can see on the compression test, the lumen is not compressed. It does take a little bit of practice, but once you get the hang of it, it's quite easy to identify the lymphatic vessel seen in the axial. And if you're not sure about it, then you double check in the color mode. And even if compression, you will not see any filling of that small lumen. And now we're tracing it with a transverse pattern to actually see the pathway of the lymphatic vessel. So here is a more clear distinction of how we do the compression test in a transverse pattern, and we're able to see a large vein near, and you could actually see that small 2 lymphatic vessel that has no signals, confirming the lymphatic vessel and a nearby vein. And after that, once we find the superficial vein, you want to trace it and see the branch of the lymphatic vein, and that branch is the target because it will give that Venturi effect. We also like to use the ultrasound to probe our lymph node in case we could do lymph node to vein anastomosis. And once we've done, and you can see that this is the actual marking, the dotted lines are the lymphatic vessels, and the straight lines are the vein, and you could actually see the branches coming out. And this is how we use the ultrasound to identify the target lymphatic vessel as well as the vein. For early stage, ICG is the main use, and then we use the ultrasound to map out the vein. In late stage, ICG can be used, but a lot of times it's very difficult to identify lymphatic vessels because of the Stardust pattern. In that case, we use the ultrasound to both mark the lymphatics and the vein. Here you could see a patient that corresponds to this marking. You could see a nearby lymphatic vessel, and you could actually see this branching out from the superficial vein, and we're able to use the superficial vein to connect to that lymphatic vessel using a side-to-end anastomosis. Similar concept here, marking the superficial vein. You can see this draining into a larger vein, and then using the superficial vein to do the anastomosis. So that was my really quick and a brief introduction of how we use the ultrasound or the ultra high frequency ultrasound to map out lymphatics as well as the vein. Remember, the ideal lymphatic vessel is the one that's functioning, the one that's largest, and the ideal vein is the one that's located close, that uses that it has a small branch from the main branch to use the Venturi effect and has minimal backflow. And by knowing where to incise exactly, even before the surgery begins, allows us to have an accurate preoperative planning, as well as increase the efficiency and allow the patient to undergo local anesthesia if the patient is feasible for it. So with that, I'll be more than happy to answer any questions. Thank you very much.
Awesome. Another great talk, spectacular images. I feel like we could talk about this all day. That said, I definitely want our audience to know, please, if you have questions, this is really a unique opportunity. You have the world experts right before you. Just put them into the Q&A and we'll make sure we get them to them. I think we have about 10 more minutes. You know, one of the, this came up earlier in the conference. So yesterday we had a pre-conference with the NIH, and they were identifying gaps in lymphatic care research as they're working towards this program called HubMap. But one of the things that came up is the need to develop more functional imaging. And JP, I heard you, you use the word functioning lymphatics. And when I looked at those images, I'm like, wow, those are spectacular. Has there been any attempt by any of the three of you or anybody else to actually try to quantitate function using the ultrasound, i.e. maybe with peristalsis or otherwise?
Yeah, this is a great question. And Aki and Giuseppe, we discussed, how we could measure the velocity or the flow using the ultra high frequency, but because the flow rate is so slow, currently even with the ultra high frequency, we're not able to measure the flow. And I think you have a radiologist in the panel, so he may agree that in order to measure the flow velocity, you have to have a certain minimum flow. So this is why vein and artery is easy to see the flow velocity, but the lymphatics is so slow, it's almost impossible. Currently, the way we try to figure out how fast the velocity moves is by capturing a real-time image from the ICG and then translating it on and trying to figure out how fast it moves. But other than that, I think currently with the ultrasound, I think there are some limitations in figuring out what is the actual velocity which correlates with function. So when I say functional, I think we mean to see large uncollapsed a lymphatic vessel that correlates in surgery. When we open the side of the lymphatics or when we open the end of the lymphatics, you have to see fluid coming out, and thus the word functional makes sense, because if you're going to connect the vein to a minimally fluid outflowing lymphatics, what's the use? So I think for now the word functional, I think, is more correlated to the surgical findings.
Yeah, I mean, I certainly agree from the radiologist perspective that, it's very difficult for us to actually detect any flow unless there's some compressive element to it. So I've been able to detect it only by actually doing augmentation, which I think you alluded to with the veins. You can do it just by squeezing it sort of at a different spot and looking for some flow to go through. But that's obviously very different. That's an artificial stimulus. I'm actually just related to that. I'm actually curious for all three of you. Aki showed this amazing images of this, this contracting lymphatic channel. Do you guys see that routinely?
Well, during surgery, under the microscope, you might see some really healthy, peristaltic lymphatic vessels. But most of the times, it's very difficult to identify unless it's a very early stage lymphedema. So for most of the advanced lymphedema patients, that we rarely see this kind of well-functioning peristaltic lymphatic vessels. What about you, Aki and Giuseppe?
Yeah, from my experience, I can see the peristaltic movement in ultrasound just only in 10 to 15% of my cases. So, but as you said, we cannot see the, we cannot check the flow speed of lymphatic vessel. But as I indicated in my presentation, because of that point, so I turn this disadvantage into an advantage. So we can differentiate the lymphatic vessel between with vein and artery, because we cannot see mosaic pattern in lymphatic vessel.
Yeah, I think Aki has a point there. I mean, if the lymphatic flow was as fast as the vein, it will be very difficult to differentiate in the color mode of the ultrasound. And again, I think, I mean, and I have to acknowledge the fact that Aki definitely is, the pioneer in using the ultrasound in identifying the lymphatic vessel. I think all of us have had Aki's guidance and help some way, and we're able to work together during the early phase of figuring out how the ultrasound plays. Aki, I just have a quick question for you, and how important is it? Because with 18 megahertz, it's very difficult to see any valves. I mean, do you see that seeing the valves actually with a 70 megahertz, you feel that it's an indication of the lymphatics having a better function? Since we're talking about function, this has been a question in my mind.
And you're talking about the valves of the lymphatics, right?
That's correct. Valves of the lymphatics.
I think we might have, it's potential we have lost Aki. I don't see him anymore.
Okay.
Oh, he's
So,
here.
Oh,
He's
here it
here.
is.
Yeah.
no signal, Giuseppe?
No, you're good. You're good.
Yeah.
No.
Yeah, Aki, I could hear you. Let me repeat the question again, just in case you didn't hear it. So, with an 18 megahertz, it's difficult to see the valves of the lymphatics. And when you're able to see the valves of the lymphatics with the 70 megahertz, do you think that lymphatic vessels has a better function?
Yeah, so, we cannot see the valve in whole of lymphatic vessel because in damaged lymphatic vessel, already valve is gone. So, the same, I can see only, 10 to 15%. I can see the valve functioning, but if there is no valve, of course, I cannot see.
Yeah, I think it's all similar.
Yeah.
Giuseppe, I mean, similar
Yes.
findings?
Yeah, similar findings. I think peristaltic movement of lymphatic channel is very interesting and, of course, very spectacular. But on the practical surgical point of view, I think is not that important, because you can understand if there is a peristaltic movement or a pressure by pushing and see the expansion. So kind of indirect sign of a good peristaltic movement. But it's not easy because, many times the lymphatic channel is very tortuous. So it's very difficult to get the axial lymphatic channel under the probe. You also must be kind of lucky to find a regular lymphatic channel.
Yeah,
Yep.
that's true.
There's a question from the audience. Do you recommend MLD following LVA procedures? what are the recommendations following surgery?
MLD.
Compression therapy, I think.
Yeah, so they want to know MLD plus minus compression therapy. What do you recommend for your patients? You can just go down the line, just a bit, Aki, JP. What do you tell your patients following LVA?
Yeah, so our protocol is we put compression bandage on the table before we finish up. So immediate compression. And we also ask the patients to do manual lymphatic drainage massaging whenever the bandage comes off. Or when the patient takes a shower, so that's probably 1 or twice a day. So I think compression, the reason why compression is an integral part after the surgery is the idea here is to drain the high pressure lymphatics into low pressure vein. And by compressing, the pressure gradient between the lymphatics and the vein becomes higher because of the external pressure increases the lymphatic pressure. And I think this is why compression is so important. Immediate to the LVA to maximize the drainage. So for us, it's immediate compression and massaging whenever the bandage is off.
Yes, I also do the same, immediate compression after surgery, and there are also some kind of garments that with with Velcro that are easy to wear for the patient, because not all patients are able to do a good compression, because if they make a wrong compression, they eventually, if they are doing a tighter compression in the upside, they can make a kind of, blockage. So sometimes it's better to give these easier garments. But I also agree that physiotherapy is integral part. I believe that physical therapy, that LVA enhance the physical therapy, make physical therapy easier. Then the patient adheres more to physical therapy, is able to learn how to do by him or herself. So everything goes smoother. And then after 1 year or around 1 year, situation becomes very stable. And then, they start to reduce stockings, compression stockings, sometimes remove compression stockings, sometimes using stockings only when they do well-performed strenuous activities. So they need to evaluate progression over months. But with compression, yes.
Yeah. Since I remember that since 7 or 8 years ago, microsurgeon presented that immediate compression therapy will, collapse the LVA point, but it is wrong. So now I saw the 2 or 3 good papers. Immediate compression after LVA will help the better result.
Great sense. Great.
Fantastic.
I think, if you look at some literature, I just want to quickly add, lymphatic vessels does not collapse even at 80 millimeter mercury.
Yeah.
So it has been shown. So I think, the compression that we do are usually 35 to 40 for upper extremity, 40 to 45, a little bit higher for lower extremity. And that even theoretically, will not collapse the lymphatics.
Thank you.
Beautiful. I'm going to ask one last question, and then we do have to close it out. Do you guys use the ultrasound to monitor your LVAs post-op? And if not, why not?
Yeah, this is $1 million question.
Okay. Maybe not the best one to end with, but does somebody want to take a crack at that?
Again, closed over the skin, in regards to function, it's very difficult to see whether or not, it's still patent. I think the ICG comes in to monitor whether or not it's functioning better for us, or the MRL. But for us, using the ultrasound as a follow-up tool to see patency is quite difficult.
Yes, I try to see that many times, but the problem is that if you go with the probe exactly on the scar makes things much more difficult, in my opinion. And so it's not that easy to follow up. Then of course, you want to follow up only, in case it's not functioning or there is a problem. Otherwise, why you want to know exactly how it is working or not? So it's also kind of maybe not practical in a way.
Yes,
Awesome.
from my experience, I tried to that from 2 years ago, but the success rate of imaging of LVA point after 1 year or 2 years is under 10%, honestly. So now I think, so I changed my mind, and I think immediate patency. It means that immediate checking of anastomotic condition is more important. So now I use another modality for checking that.
Thank you.
You know, I think as the three of you are legends in our field, you're really pioneers in what you're doing with lymphatic surgery and ultrasound, and it's really an honor for us to have all three of you here. Great interaction, great conversation. For the lymphatic surgeons out there, you know, some of the takeaways I'm going to take away from this is, you know, no matter what your algorithm is out there for your workup, if ultrasound's not part of it, it probably should be, and you should be looking into it. And for us internally, I think maybe something for us to consider is that we've really been relying on ICG to guide our ultrasound, and maybe we need to expand some of the indications for ultrasound, even in, you know.
Don't see linear channels, you can still.
Yeah.
Exactly.
You
In
still take
more
a look.
advanced disease.
Yeah.
Awesome. Thank you a lot, guys.
Thank you.
Thank you.
Thank you very much.
And this
Yeah.
concludes this section, the imaging session. And I'd like to thank all of our speakers, especially those, actually most of them from afar. So thank you, everybody. Have a good night.